I'm Lisa Hutchison, and I'll just introduce myself briefly. I work at the University of Arkansas for Medical Sciences in Geriatrics at the Donald W. Reynolds Institute on Aging. I obtained my degree from the University of Tennessee. I got a Bachelor's of Science in Pharmacy and then a PharmD there. Then I also received a Master's in Public Health at the University of South Florida. I hope you'll enjoy geriatrics. I say it's the one special area that's going to touch almost everybody, even if it's not your patients. It's going to be your family, and you just can bet on that being an issue at some point in your life. So I have no conflicts of interest for this subject matter. And you can see here my learning objectives on these next two slides is summarizing age-related issues and assessments, and then we're going to focus on some disease states, dementia in particular, and the behavioral and psychological symptoms of dementia. Then we'll also go into urinary incontinence, including BPH treatment, and osteoarthritis and rheumatoid arthritis. Here's my outline. You'll be able to kind of follow where we're at along the way. But obviously, pharmacotherapy in older adults is an increasingly important issue. We have more and more older adults, plus the epidemiologic information shows us that these are the individuals that have the most adverse drug events. We use the most medications in this group, and they have the highest costs associated and bad outcomes. So to me, it's a very important thing to stay current with because you're going to be the front line at trying to reduce this. Now, most of you probably remember from pharmacy school the common pharmacokinetic changes that are seen in older adults. I have them summarized here. Absorption, we have some drugs that have a delay or a reduction in their absorption. It's not very many, and the ones that it occurs in, if they're chronically used, we tend to be able to readjust very easily, and it follows one another. Transdermal patches are less predictable in older adults. Their skin and the fat pad under their skin from person to person can change, and so it's not always predictable, and this is especially information you need to keep in mind when you're starting a fentanyl patch because it's such a narrow therapeutic index. Distribution is generally the volume is increased for drugs that are fat soluble, decreased for water soluble, and then if we have high protein binding, and many times our older adults are malnourished and have low albumin and other proteins in the serum, and so we have an increased free fraction. Metabolism may be reduced. The liver is smaller. The first pass effect is decreased, so we have higher bioavailability. You can use that kind of information as well as the others for new drugs on the market to really associate that the patient that's older is likely to not react the same as the younger patient as far as the pharmacokinetics. And then elimination is generally decreased. This, of course, is focused on kidneys and renal excretion. Other elimination may not be changed as much, but that one is an important factor. And I'll just show here with this chart that the information we have on the MDRD, which is so commonly reported now by our laboratories, and helps us to estimate GFR, has really not been validated in our oldest population, as well as it's not got as many studies showing where it would be as applicable for drug dosing. And so we still put the Cockcroft-Gault creatinine clearance formula first as the way that we want to adjust drug dosing in our older adults. In addition to the changes in pharmacokinetics, we'll see changes in pharmacodynamics. And most often we see an increase in sensitivity to many of our medications that we can't explain by pharmacokinetic changes. In particular, central nervous system drugs like the benzodiazepines and the opiates, antipsychotics and tricyclic antidepressants, we see an increased sensitivity, especially to many of the side effects. Warfarin and nonsteroidal anti-inflammatories. Warfarin, we see increased risk for bleeding in older adults. Nonsteroidals, we see increased GI bleeding with those. And then anticholinergics, especially in those that might have some kind of underlying CNS disease state, we see an increased sensitivity to the delirium side effects, but also to the constipation and dry mouth with anticholinergics. Decreased sensitivity has been demonstrated with beta receptor drugs, and so the beta receptors tend to downregulate in older adults, probably because norepinephrine and epinephrine levels are higher in this group, so they downregulate, and the initial use of these drugs in a patient will maybe not have as brisk a response as we might otherwise see in a younger adult. However, these receptors will upregulate with time, and so you will see response. Lastly, what I have seen over and over, especially in a hospitalized patient setting, are impaired homeostasis. And so these drugs that are affecting our electrolyte or our fluid balance that you see listed here, as well as others, we tend to see if those get out of balance for our older adults, it takes much longer for them to re-equilibrate, even if we, do the right things. So, for instance, if we have a sodium issue that we're wanting to restrict fluid in a younger patient, that might be all we needed to do, and they would respond on their own. But in an older adult, it takes much more effort, and many times we have to add some sodium if it's a hyponatremia, and it won't respond as quickly in an older adult. So I have the first case here is an 85-year-old woman that resides with her daughter, and she has type 2 diabetes as well as hypertension, and she status post a hip fracture. You can see here her list of medications, including glyburide, lisinopril, metformin, aspirin, multivitamin, melatonin is needed, and meclizine is needed, and then Docusate twice daily. Her labs are pretty remarkable, especially for the kidney labs, the BUN and serum creatinine. And so we might want to be a little concerned about this lady and think about what pharmacokinetic changes might be occurring and which medications would be most likely to cause a problem for her.